Good morning to everybody, whoever is attending my class. Today my topic is headache. Headaches due to increased intracranial pressure. Headache is most likely to occur when there is an increased pressure gradient between intracranial compartments. Such gradients may stretch or distort the pain-sensitive structures such as the dura, arachnoid, blood vessels, and or nerves. This occurs most commonly when an intracerebral mass lesion such as tumor, subdural, epidural, or intraparenchymal hemorrhage or abscess or parameningeal infection is present. Other symptoms depend on the specific brain structures that are affected. For example, the posterior fossa mass may compress the cerebral aqueduct, thereby causing hydrocephalus. Consequently, symptoms may include a decreased level of consciousness, apathy, and akinetic mutism. In a direct compression of the brainstem and or cerebellum may cause the compounding of nausea, vomiting, and ataxia. The headache from an intracerebral mass lesion may worsen abruptly with bending over and may awaken the patient from sleep during the night. Headache may result from apparently generalized increased intracranial pressure. The best example is idiopathic intracranial hypertension, also called pseudotumor cerebri or benign intracranial hypertension, in which the intracranial pressure may be markedly increased. 75% of patients with idiopathic intracranial hypertension have headaches. This IIH occurs most frequently in the obese young women. 8 women are affected for every man. In some cases, IIH is associated with menstrual irregularity, pregnancy, use of oral contraceptives, weight gain, excessive intake of vitamin A, withdrawal from corticosteroids, or treatment with tetracycline, nitrofurantoin, or nalidixic acid. In a minority of patients, there may be history prior to head injury, prior head injury or meningitis. Common symptoms may include headache, pulsatile tinnitus, or less frequently, diplopia. Neurologic signs include papilledema and rarely dysfunction of the sixth cranial nerve, and even less frequently the third, fifth, and seventh cranial nerves. CT or MRI of the head may document small slit-like ventricles and sometimes an empty cella. A spinal tap quantifies the increased pressure above 250 mm of water with normal CSF cell counts and chemistry, while at the same time serving as a means of pressure reduction when these obese patients with pseudotumors lose weight. Their CSF pressure may normalize and their symptoms may resolve. If the patient is taking a non-essential hormone such as estrogen containing birth control pill or another causative medication, then its continuation should be the first priority. If the CSF pressure remains elevated, then the serial lumbar punctures, sometimes combined with diuretic treatment, are warranted. Acetazolamide is often the diuretic of choice. Acetazolamide is often the diuretic of choice if those measures are insufficient. Then the refractory cases, a lumbar peritoneal or ventriculoperitoneal shunt can be installed. It is important to be aware that tonsillar herniation is a rare complication of the lumbar peritoneal shunting. In addition, in most children, the herniation is asymptomatic, but serious consequences requiring the surgical interventions occur in a small minority in children. Serial MRIs to look for tonsillar herniation may be warranted. In IIH, a reduction in CSF pressure is important. Is important because long-term elevation can result in the permanent impairment of vision in 4% to 12% of cases. the possibility of subdural hematoma must be neglected. A reduction in CSF pressure is important because long-term elevations can result in permanent impairment of vision in 4% to 12% of the cases. A possibility of subdural hematoma must not be neglected. A history of trauma followed by unilateral headache, hemiparalysis, drowsiness is powerfully suggestive. However, the causative trauma may be remote, minimal, or there may be no history of trauma at all. Patients taking medications with anticoagulant or antiplatelet effects, the latter including all non-steroidal analgesics, and are at much increased risk for development subdural hematoma. Lateralizing signs may be absent. The CT is an important diagnostic aid, but bilateral subdural collections often are missed if the patient is sufficiently anemic or if the CT is obtained during the interval 1 to 6 weeks when the collections may be isodense with a adjacent brain tissue. Thank you. I come to the end of my today's lecture.